sequelae and issues that we see in Prader-Willi syndrome that I didn't necessarily want to list and go through every single one, but just to give you an idea. And that in infants and toddlers, it's important to note that we see kind of an opposite end of the spectrum compared to the older children who have the hyperphagia. We tend to see more issues with hypotonia, poor appetite, feeding difficulties, lethargy, developmental delay. And then you can see failure to thrive, respiratory issues, as we had discussed, and then some early endocrinologic dysfunction. And then you can see specific dysmorphic features, as well as cryptorchidism in males. And then when you're on the older end of the spectrum with children and adolescents moving towards adulthood, we still do see hypotonia and muscle weakness, but then start to see more behavioral issues with temper outbursts, emotional lability, comorbid psychiatric disorders. Skin picking is a specific issue in Prader-Willi. And then there's a list of several other issues. And then to kind of point out the hypothalamic dysfunction here, as I mentioned, short stature, growth hormone deficiency, obesity related to the hyperphagia if the diet intake is not controlled, and then central hypothyroidism, reduced bone density, and central adrenal insufficiency, and again, hypogonadism down here. So I point all these out because they do apply in our case. So just to start going through this case and recognizing that this is a rare syndrome, I have changed just some of the details for the patient's confidentiality. But as I mentioned, this is a young lady that I saw in the outpatient psychiatric clinic who was referred by Dr. Clarson to Dr. Nicholson's office. So this is a 15-year-old girl who was diagnosed with Prader-Willi syndrome in infancy. Her presentation, as the parents had described to us, was with hypotonia. They described that she was born and then had some poor feeding. I think they actually did go home and then came back because the baby continued to feed poorly. It just had very poor tone, and then were sent to a tertiary hospital where the baby spent several weeks with feeding difficulties and was ultimately diagnosed with Prader-Willi syndrome, which was found to be secondary to a 15q microdeletion, which I suspect was in the paternal chromosome, although I was unable to actually find the gene report going back through her records. But from the genetics documentation, that seems to be the case with her. Her main ongoing issues, although she does have several other minor medical comorbidities associated with Prader-Willi, were premature adrenarche and central hypogonadism, for which she was started on estrogen replacement early in life and then for pubertal induction and bone health, and then was subsequently switched to an OCP, an oral contraceptive, in adolescence for ongoing maintenance of endometrial health and bone health. And then the patient also had central hypothyroidism that is being treated as well. In terms of growth, it's just important to note, and I've included this growth chart here, that children and adolescents with Prader-Willi syndrome do have specific growth charts for Prader-Willi because we know that their growth rates are different, just to keep in mind if you're seeing any of these patients. So our patient was started on growth hormone treatment as a toddler and continues on treatment now. In terms of the obesity and hyperphagia, which is a common trait in Prader-Willi and to see in adults with this syndrome, our patient actually has a normal BMI at the present time, and that's because the parents have been absolutely meticulous with limiting dietary intake, making people in her life aware of the condition and the important things to look out for in maintaining good nutrition. They limit free access to food and have a lot of control over the food that she has access to. And then she has 24-hour supervision both at home and at school to limit food foraging behaviors. And then the parents are well aware and have made the people in their circle of care aware that if there is vomiting, this is commonly recognized as an emergency sign in children with Prader-Willi syndrome, as they have a higher threshold for vomiting, and we don't tend to see vomiting as often, and can be an emergency sign of gastric rupture. In terms of the more psychiatric and developmental aspect of her case, she does have an intellectual disability, as I mentioned, is common in Prader-Willi, and so has an IEP and an educational assistant present with her at school.
But I'm just about to present in a Zoom meeting, so can I call you back after 5?
She did have IQ testing before school, which showed a moderate delay in expressive language, and did see occupational therapy and speech language therapy at that time. And then again had testing in kind of the early school years, showing severe language delay and comprehension skills. At that time, there was some kind of more details to the testing showing that she had good rote skills, meaning that she has good repetition abilities, but limited application of those abilities. Reading skills at that time were low average, but comprehension was below the first percentile, and parents were understanding of that. She did go on to have further psychological testing more towards high school to better understand her needs and review things as she progressed through school, which showed an overall functioning in terms of IQ at the 0.1st percentile, showing comprehension at kind of a mid-grade 1 level and oral expression at the 0.3rd percentile. So she does have an intellectual disability, and a lot of her main difficulties are around comprehension and expression. In terms of the psychiatric concerns from the family, they did have behavioral concerns and noticed outbursts since early adolescence, which again is not uncommon in Prader-Willi. She experienced increased anxiety, and this was affecting her functioning at home and at school. She has had skin-picking behaviors in the past and has had occasional fixed interest. And then the main reason for her psychiatric referral from Dr. Clarson's office was that she was having increasing outbursts as time went on, and she was getting older, more emotional dysregulation with anger, crying, and sadness that really concerned the parents, and then showing aggressive behaviors with throwing and yelling both at school and at home. Was showing again some of those fixations in her conversation, was exhibiting poor disrupted sleep, had decreased appetite, which the parents were understandably concerned about, as this is fairly uncommon in Prader-Willi syndrome. And then the parents had noticed some self-talking that had concerned them for possible hallucinations. I think the patient had had some behaviors of self-talking in the past that seemed kind of harmless and talking herself through instructions of daily life. But then as time went on, it started to take more of a concerning nature, where the parents had heard her talking about more things about like, you want me to hurt myself or something like that. So that's what prompted the referral. On assessment with psychiatry, it was kind of over the past several months, so it was by video conference. But kind of all that said, in talking to the parents and the patient, it was determined that she did have significant emotional dysregulation, and that the likely diagnosis was depression with psychotic features, versus, of course, monitoring as time goes on for a psychotic disorder such as schizophrenia, versus potentially a variation of normal, given that she's had this self-talk for quite a while, and that it was difficult to really gather from the patient what she was experiencing. So at that meeting, it was discussed kind of different options in terms of medication, given the diagnosis of depression with psychotic features, and ultimately was decided to treat with risperidone. And that was kind of to target the behavioral outbursts, sleep, and these possible hallucinations together. There was discussion to start an SSRI or an antidepressant as well, but I think in talking to the parents and with the resident that was seeing them at the time, the decision was ultimately made to start risperidone. And the patient tolerated this quite well. She had minimal weight gain, which of course is an important consideration for her, and then started to show improvements with mood and with the behavioral and emotional outbursts that she had been seen for. So again, they had discussed adding an antidepressant, but the parents felt that they had seen appropriate improvement in her mood at the time, and so wanted to hold off and just continue titrating the dose of her risperidone. And so when we met with the patient, things were fairly well from a behavioral and emotional point of view, but the mom had brought up just in our discussions about anything else going on, a new concern. So as I mentioned, our patient does have hypogonadism, which Dr. Clarson will discuss a bit more in depth, but had been started on an OCP for endometrial health maintenance, and specifically the OCP was cyclin, which is a combination of estrogen and progestin. And the way that they were taking this medication was for 12 weeks at a time straight, then with a 1 week break to prevent menses, and then to restart with the 3 months of treatment. And this has been what they've been doing for some time. And this was the first time that mom had noticed that on discontinuation of the cyclin after that 3 month period, and with menses, mom had noticed some clear bilateral nipple discharge. She noted that it was kind of leaking through the patient's clothes and hadn't really mentioned anything because she didn't want to bother her daughter with it too much, but did mention it at our appointment appropriately. What sounds like galactorrhea resolved with resumption of the cyclin after that 1 week of menses, and hadn't occurred again at the point that we were talking. She had otherwise been asymptomatic, no headaches, no vision changes or anything concerning for kind of neuroanatomic reasons for galactorrhea. So we had discussed with the parents, of course, that galactorrhea can be a potential adverse effect of risperidone, and made them aware of this again and kind of talked through that. However, they felt that given the benefits that they'd seen already in starting the risperidone, they felt that in weighing the risks and the benefits, that it still seemed appropriate to continue on that and just to follow up closely with endocrinology. So we did call Dr. Clarson and have a discussion about this after we saw the patient to come up with kind of a further plan and have her prolactin measured at their next appointment. And that is kind of the end of what I have here for our presentation. So does anybody have any questions about the case presentation before we move on to Dr. Clarson's piece?
All right, so there is a hand up by Dr. Balche, who I will allow.
Hello?
Yeah, Tuche, you should be unmuted now.
Okay. I just wondered, we have read many articles lately that if the diet is followed as religiously as has happened with this family, and if the BMI is within normal limits for a child with Prader-Willi, that the behavioral and intellectual outcome is could be better than what is expected. I'm just wondering, I know this is just one case, but based on other people's experience, was that the case in this girl that actually the disabilities seen were perhaps milder than what one might imagine? I'm guessing the answer is no, but just wondering if anyone can perhaps compare it to another 15-year-old that they have seen who was obese.
Kierston, do you have any thoughts about that?
I can't say that I've seen any other patients with Prader-Willi of this age who have had different dietary control. So that's an interesting point, and I'd be curious to know if anybody has had that experience.
Tuche, one question that I'd have along the same lines is, with regards to the size of the mutation that people have with Prader-Willi, does that have any impact on the severity of the syndrome at all?
Thank you. No, because it's not really a size issue. So either the region is deleted completely, or there is UPD. But there are differences between cases with deletion versus UPD. But mostly the differences are in physical differences. For example, the ones with the deletion tend to be fairer than their family because the gene for the melanin is also gone. Whereas if it's UPD, it's less likely to be the case. I have read that the UPD has slightly better developmental outcomes than deletion. The imprinting defects are exceedingly rare, so I don't think we have enough data there. So that's why I was curious, because I read that one of the predictors of outcome was actually dietary control, but it was based on a few cases. So I'm not sure if it's overall general, but I'm just wondering if anyone, if Rob, yourself, or Dr. Clarson has seen that before in anyone else. And, you know, I have seen my fair share of older kids with Prader Willi who are obese, who did not have good control, and they were in the severe intellectual disability spectrum. This girl seems like she's more moderate, if I'm not too mistaken, but yeah, so just wondering.
So I've only ever personally seen 2 people with Prader-Willi syndrome, so it's obviously a tiny number, and both actually their parents had been scrupulous about their diets. Neither of them was actually overweight, but the other boy I saw a number of years ago, he was much more severely affected than this young lady is. So in my N of 2, it hasn't made any difference to cognitive ability, but that's not a good sample size.
Okay, thank you.
Claire, you had a question or a comment?
Yeah, so I have had a handful of patients with Prader-Willi, and I would say the biggest factor in terms of how they have done has been their caregiving environment. So I've had patients who have been, I can think of one in particular that was in foster care, switched parents, and development changed actually quite dramatically. So I'm just wondering if the attention to the diet is more of a marker of kind of parental involvement and enrichment in their environment, and whether it's to do with that or the actual weight itself. So I haven't read all of that literature, but I do think that, you know, things like the picking behavior and all of the other behaviors that parents are able to address those in an appropriate way, the kids do a lot better than when they live in a less stimulating environment.
So Dr. Mitchell, have you been reading Dr. Ogilvy's mind today? So I think Jacqueline had the precise same comment, if I'm not mistaken.
Think alike.
Jackie, you should be.
I was going to say, great minds think alike.
Yes, that's half the phrase, I believe.
That was my comment. So yes, nothing to add.
So and you know, and I think that Kierston made a very good point. I mean, these parents were scrupulous about it, and talking to me, they seem like people who understand Prader-Willi syndrome and have a good sense of that, and obviously have been on top of things from a very young, from a really young age. I mean, Cheril, how long have you followed this young lady for?
Unmute. Yeah, can you hear me now?
Yep.
Yeah, I followed Chloe since 2004 when she was 8 months, and that will be made clear in my presentation. And as you say, these are very good parents. They have advocated extensively for her right from infancy.
So do you? So I guess with regard to Claire's question and comment and Jackie's and to Chay's comment, I mean, do you think that might be the factor more than anything else, that rather than the diet and maintenance of it itself, that parents were able to do other things as well?
So you think that's more important than the endocrine intervention? Is that what you're saying?
Oh, I think the mental health aspect is always more important than the endocrine aspect of things.
Yeah, I think that's undoubtedly makes a big difference. I mean, I don't see a huge number of patients with Prader-Willi, but most of them are significantly obese, unlike this girl.
And I think just in talking to the parents and her, even when we would ask the child questions and she would kind of hesitate to answer or look at her parents, the parents would really encourage her and push her to answer every single time. So they've had a lot of, I think, patience and really encourage her to keep trying and see a lot of strengths in her as well.
But at the same time, I think have a realistic understanding of what her strengths and weaknesses are.
For sure.
And so the sense I had, and obviously Cheryl, you know them way better than any of us ever will, but was that they accept her for who she is, strengths and weaknesses together?
Yeah, absolutely. I don't think they have unrealistic expectations.
Tuche, you had another comment or question?
Yes, sorry, I just remembered. Maybe Cheryl will touch on this, so maybe I should wait until she's finishes her presentation. But the effects of growth hormone, I was just going to ask about.
I can't wait to tell you about.
Okay.
Okay,
So
I'll stop sharing my slides here so that.
So before Cheryl comes, I mean, does anybody have any thoughts or comments about the use of risperidone here? So when the resident who was seeing this young lady came to me and suggested it, at first I had, I don't want to say I thought she was a bit out of her mind, but it just seemed like not an obvious choice in somebody who already has, Prader-Willi syndrome. And yet it's turned out well for her. Does anybody have any thoughts or comments about that or other things that could have been done? All right, so crickets. So before we move on, that I just there's one comment. So the so Farah Dr. Abdul Sadr had asked about checking prolactin routinely, and so this in all honesty, Farah, this is one of the many reasons I had asked Dr. Clarson to join us, because this comes up a lot with antipsychotics and psychiatrists not generally knowing much about. Not knowing enough about prolactin and things. I think people often get very worked up about elevated prolactins, and that's why one of the reasons I say is I'd asked Dr. Clarson. So I don't think we've actually measured this young lady's prolactin yet since we saw her. Is that right, Kierston?
Yeah, I believe so. I think we had discussed maybe bringing them in to do it, and then had chatted with Dr. Clarson, and we're going to plan to do it all with her next endo blood work.
Yeah, which I think is in the next few weeks or so. And I think, in all honesty, I don't think we saw a reason to, because it was quite apparent that her prolactin was going to be elevated. And I think that getting prolactin level, we know it's going to be elevated, seemed like if getting blood is difficult, something that wasn't necessarily going to be of benefit to everybody at the time, that when she's going to be here in the next few weeks, the plan was to do some blood work then. And I think Dr. Clarson's going to answer your other questions, Farah. The other thing before we move on to Dr. Clarson, I just want to say that if people we have received approval from the Canadian College of Family Doctors and Royal College of Physicians and Surgeons of Canada, and I believe the College of Psychologists for continuing education credits. However, in order to provide them, we need people's real names in their that they sign in with. So if people can just go to their name in the list of attendees, if you're all able to see it, and just correct the names that we can recognize many of them, but not everybody. And so just if people need credits, if they could provide that for us, their name, that'd be fantastic, please. So, and we will move on then. So Dr. Clarson is our next speaker. Dr. Clarson is a professor in the Department of Pediatrics at Schulich School of Medicine and Dentistry, and is a section head in pediatric endocrinology at London Health Sciences Center. She completed medical school at the University of Nottingham, and then did her residency in Nottingham and also Birmingham before moving to Canada. So Dr. Clarson has held peer-reviewed funding from the Canadian Diabetes Association, the Juvenile Diabetes Research Foundation, and CIHR. Her current research focuses on clinical trials in type 1 diabetes. She is a co-principal investigator on a multi-center study of structured transition on diabetes care in adolescents with type 1 diabetes. And she was also co-chair of the Transition to Adult Care Working Group established by the Ontario Pediatric Diabetes Network, the Provincial Council for Maternal and Child Health, and co-authored the report in 2016 entitled Transition to Adult Care Working Group Recommendations Report. Dr. Clarson has numerous publications and grants, and I I think I've told many residents this over the last 20 years that when I was in medical school, Dr. Clarson, in the brief time I worked with her, had numerous sort of clinical pearls that have always been of great value to me. So I think as a clinical teacher and a clinician, she's wonderful. And I'm not buttering you up just because you joined us today, Claire. But anyway, welcome. Cheryl, welcome, and you're up.
Okay, so can you see my slides okay?
Yep.
Mm-hmm. Yep, good. All right, and thanks for those kind words. Rob, I should correct you. I'm no longer division head of endocrinology. That's now Dr. Stein. Okay, and I have no disclosures. So I'm going to focus on growth hormone and hypogonadism, and then talk about antipsychotic induced hyperprolactinemia. I will skip over some of my slides because Kierston has very nicely addressed some of this. So with respect to endocrinopathies, the ones I'm going to focus on are growth and puberty, but I'll just also mention these other endocrine issues. And as you know, these children with Prader-Willi initially in infancy have poor feeding, failure to thrive, and then transition to obesity and hyperphagia. And these 7 phases of nutrition were described by Miller. And it's interesting because, in fact, I always thought the hyperphagia preceded the obesity, but it's the other way around. The hyperphagia starts first, which may be the obesity starts first, which may be associated with ghrelin, and then the hyperphagia. And of interest, as adults, they no longer have this problem with satiety. And then with respect to growth in height, these children grow slowly from infancy, unlike the obesity, which doesn't usually start till around age 2, and usually do not have a pubertal growth spurt, even with hormone replacement. And the mean final height for females is 147 centimeters. For those of you who are still in imperial units, that would be 4'10". And for males, 160 is the mean final height, which is 5'3". And these children, even if they are not obese, they still have poor body composition with decreased lean fat mass and increased fat mass, which predisposes them to all the problems associated with metabolic syndrome like type 2 diabetes. And Kierston showed you some Prader-Willi growth charts. So on the left are for males and then females on the right. And what you can appreciate is, so the shaded area, this is the 50th percentile for height for, let me just get it right here. So the shaded here, this is for non-PW kids. And here is the 50th percentile for children and adolescents with PW. And you can see there's a fair amount of overlap, but they really miss out on not getting that pubertal growth spurt. These are the weight curves, which don't start till age 3. And you can see by age 3 already, most of these children are in the obese range. So there's been a fair amount of interest and publications with respect to growth hormone. These consensus guidelines, which were formulated by 43 stakeholders and experts, were published in JCEM in 2013. And basically, they recommended the use of growth hormone and made the point that cognitive impairment should not be a barrier to treatment, but also emphasized the importance of reviewing risks with families, and in particular, ensuring that there was no obstructive or central apnea prior to starting treatment, because there have been reports of unexpected sudden death in children with PW, particularly within the first 6 to 12 months of starting growth hormone therapy. And it is not clear if there is a definite relationship, but what is speculated that perhaps with growth hormone therapy, which induces increased IGF-1, which impacts on lymphoid tissue and lymphoid hyperplasia, that could contribute to obstructive apnea. But the take-home message from these guidelines was that growth hormone should be started ideally before the onset of obesity, because there is evidence that this can attenuate the hyperphagia. And so the recommendation is to start treatment by the age of 2. Now, one of the challenges is funding for growth hormone. And growth hormone was first approved in the US in 2000 for growth failure in Prader-Willi, and in 2001 in Europe for improving body composition. But we have badgered and advocated for the last 2 decades for Health Canada to approve, and parents, have been very active in advocating. But it wasn't until December 2019 that in Ontario, the Ontario Minister of Health actually approved funding through EAP for growth hormone in Prader-Willi. But that still may often involve a co-payment for families. Sometimes we actually do the growth hormone testing, because if a child is confirmed as classic growth hormone deficient, then we can get funding much more easily through a provincial program. So I'm going to continue with Chloe. And you heard quite a bit about her from Kierston. So as I say, I saw her first in 2004 when she was 8 months old, and her parents' heights are there. So she had a target height of 175 centimeters, which would be about 5'9". And when I saw her at 8 months, she was already below the 3rd percentile. And the parents specifically sought an endocrine assessment because they wanted growth hormone therapy for her. And this is prior to the 2013 consensus guidelines. So at that time, I suggested that we wait until she was 2 because we needed to do provocative growth hormone testing, and which is fairly arduous and involves putting in an IV and about 4 hours of sampling. So it would be easier when she was a bit older. So when she was 2, we did the provocative growth hormone testing. We also measured an IGF-1, which interestingly is in the normal range. So to make a diagnosis of growth hormone deficiency, we require 2 tests with a peak growth hormone value no greater than 6. And for Chloe, ATT is arginine, so her peak value with that was 2.6, so she basically failed that test. We usually then proceed to a second provocative test, which would be clonidine, but she was hypoglycemic, which can be a symptom of growth hormone deficiency, so we suspended the test. So based on those data, we were able to get funding for growth hormone for her. At that time, we didn't have access to sleep studies, but she was seen by a respirologist who considered that she didn't have any evidence of upper airway obstruction. So, and her parents have given me permission to share these pictures. So this is her at age of 2 when we started growth hormone. And she did very well. She had a good growth hormone response. Here she is, her head is peaking above the parapet. Mm-hmm. And as well as growing rapidly, she grew 10.5 centimeters in the first year. Her parents, and this is subjective of course, but the parents also reported a significant improvement in her energy level. And then here she is at 5, where she is well above the parapet and looking good. And so at that time, her height was on the 25th percentile for the typical growth chart and above the 50th for the Prader-Willi chart. And this is an ordinary growth chart, and you can see that this is where she started growth hormone when she was just below the 3rd percentile. She had a very nice response up to the 25th percentile. She finished growing at around 14 and with a height of 156 centimeters. But she remains on growth hormone for the other benefits, particularly body composition. It's still a daily sub-Q dose, but it's a lower dose than is required for growth. And you can see her weight kind of stayed fairly steady, close to the 50th percentile. And on the PW charts, you can see that her height accelerated nicely and the weight remained pretty steady. So, and as I say, she remains on growth hormone therapy. Particularly for the long-term benefits with respect to body composition. So I'll pause there. I'm going to go on and speak briefly about hypogonadism. Do people want to raise any questions now, or should I press on? Shall I crack on, Rob?
I can't see anybody's hands. Oh, sorry, there's one question or comment from Dr. Ogilvie. Jackie, I'm asking you to unmute yourself. There you go.
Great. I was just wondering, do you need to do the STIN test in Prader-Willi to identify the growth hormone deficiency?
No, good question. And I think I missed out a slide with the prevalence of growth hormone deficiency, and it's estimated at between 40% and 100%, and it depends what criteria you use. But really, the only reason for doing testing is for funding. And a proportion of kids with PW will be deficient on testing, but their response to growth hormone is not predicated by their response to testing. So we were happy when finally in December, Ontario approved the EAP funding for growth hormone without the need for provocative testing. And even without, I have some children who are growing appropriately and on the ordinary growth chart, but I would still recommend growth hormone therapy for the other benefits, particularly the body composition benefits.
I don't think there's any other questions right now.
Okay, so I'll talk briefly about hypogonadism. So a bit of physiology here. And, one of the reasons endocrinology is so attractive to some of us is because it relates directly to physiology. So if you remember, hypothalamus producing GnRH stimulates pituitary to produce LH-FSH, and then stimulating gonadal sex steroids, and which then does negative feedback to the pituitary. So the hypogonadism in PW has generally been attributed to hypothalamic dysfunction, but there are some recent studies showing a primary testicular defect in males. So traditionally in PW, the LH-FSH would be low and low gonadal sex steroids, but there are some individuals where both males and females where they have a low LH level, but a higher FSH level consistent with a primary gonadal problem. And in terms of presentation, they may present in infancy with genital hypoplasia, particularly micropenis and cryptorchidism in boys. And then most of them do not go through puberty. Some do, and some of the girls will start breast development, but then not proceed to menarche. If they do have spontaneous menarche, they usually progress then to secondary amenorrhea. Most are not fertile. I could find details of 4 pregnancies in young women with PW, so it is important to counsel in terms of contraception, but there have been no cases of paternity. So in terms of the management, most of these children and adolescents will require hormonal replacement. And apart from inducing puberty and maintaining pubertal development, also important for bone health, muscle mass, and probably general well-being. And we aim to mimic what would be happening physiologically in terms of dosing and timing. And for our patient, we started a low dose of estrogen at 12.5, a dose that wouldn't be enough to promote breast development, but would provide bone protection. And of course, when we're discussing when to induce puberty, this is done in collaboration with the family and the child or adolescents. For adults, sex hormone replacement should be considered if there's amenorrhea, oligomenorrhea, or low bone density. And for adults, testosterone administration, I'm not going to go into this in detail. I'm going to summarize here the screening, monitoring and recommendations. So for growth hormone, again, in response to Jackie's question, no formal testing is required, but really important to do baseline testing, including sleep studies. For hypogonadism, looking for undescended testes, monitoring for puberty. Hypothyroidism, about 20 to 30% of kids will develop central hypothyroidism. So this won't be picked up just with a TSH, so important to check a T4 as well. And the recommendation currently is to start screening at 3 months of age and then continue annually. Central adrenal insufficiency, so ACTH cortisol deficiency, not well documented. There is some evidence for an increased prevalence. And one of the recommendations is that if a child is having surgery, then certainly consider stress dosing at that time. We're not going to talk about obesity because that could go on for hours and hours. So I'm going to move on to talk about hyperprolactinemia. And here is another lovely picture. So anterior pituitary lactotrophs produce prolactin, and dopamine produced by the hypothalamus inhibits prolactin production, combines with the dopamine receptors. And of note, prolactin is the only anterior pituitary hormone that's under inhibitory control rather than stimulation. And prolactin synthesis and secretion is also stimulated by TRH and by estrogen. Hyperprolactinemia can be classified into 3 main categories: physiologic, and venipuncture can be, the stress of venipuncture can be associated with an increase in prolactin of the order of 40 to 60. So if you are seeing levels of that order, then it's certainly worth repeating the level. And then then pathologic and pharmacologic, which I'm going to go into a bit more detail about. In terms of pathologic causes, pituitary tumors are the most common pathologic cause of hyperprolactinemia, and prolactinomas are the most common type of pituitary tumor. And the level of prolactin usually correlates with the size of the tumor. A macro adenoma, the prolactin level would usually be over 500. If you see a level 250 to 500, that would usually be consistent with a microprolactinoma. The drugs, so it's your drugs, the antipsychotics, which are the main culprits here, and risperidone, which was mentioned, and metoclopramide are the main, are responsible for the highest levels of prolactin. They can be associated with levels of prolactin up to 200. Most would be lower than that. And in one study of 106 patients on atypical antipsychotics with hyperprolactinemia, the risperidone was the main culprit, with 81% having hyperprolactinemia. So with chronic use, 40 to 90% of patients maintain elevated levels, somewhat higher with risperidone. And I don't know if this is a medication that you use routinely, aripiprazole, but apparently hyperprolactinemia is rare with that because it's a partial dopamine agonist, and that may be a consideration if there is a problem with one of these other drugs. It may be a consideration to change, but you would know more about that than me. So with drug-induced hyperprolactinemia, levels would range from 25 to 100. I mentioned the main culprits, and the mechanism is a dopamine antagonistic effect. There are various responses in terms of the dopamine receptor, which likely affects the levels. And if this is drug-induced, then the levels would decrease to normal within 2 to 4 days of discontinuing the antipsychotic. What are the effects? Well, you heard about galactorrhea. In many, it may be asymptomatic. Hypogonadism, infertility, and then bone loss if it's persistent. The Endocrine Society came out with some clinical practice guidelines around treatment in 2011 and haven't updated since, but I think this is quite useful. So in a symptomatic patient, they are suggesting discontinuing the medication for 3 days or substituting an alternate drug and then remeasuring. And I suppose what I'm interested in is, do you routinely measure prolactin prior to starting these medications? Because obviously it would be useful to have a baseline to compare. And obviously not to discontinue or substitute a different agent without consulting the patient's physician. And if the drug can't be stopped and the onset of hyperprolactinemia doesn't coincide with starting therapy, they recommend obtaining a pituitary MRI. So to summarize, management should include availability of alternative medications, and I'd be interested in what those of you who are experts on this have to say. But there's no need to treat if the patient's asymptomatic. And for our patient, given that she has fairly minimal galactorrhea, I think that from talking with Rob and Kierston, the benefits of her medication certainly outweigh that. If someone is going to be on antipsychotic medication long term, and then there's the risk of hypogonadism, particularly low bone mass. So if they're not already on sex steroids, then consideration should be given to replacing that. And I'll just put up this slide again because I think it's very explicit. So I would welcome any questions, discussion.
Thank you, Cheril. That is fantastic, and I think so what the American Psychiatric Association recommends, I think, and Richard, other people may be more up to date than I, but I think they recommend testing prolactin several times a year. And I think we try to do things, but ahead of time. But many of the kids we see, particularly here at CPRI, have significant behavior problems, and so doing blood work before starting medication sometimes is a difficult thing to do, and certainly doing it several times a year, I think becomes very hard as well. I mean, I think you and I had talked about this a month or two ago with regards to this young lady, but if people have sort of minimally elevated prolactin levels, so in the, 35, 40 kind of range, is there anything that we should do, or should we just follow that along, do you think?
Yeah, no, I wouldn't do anything. I would just follow, and I don't think you need to follow it that closely. I mean, if it's fairly clear that the increased prolactin coincided with starting medication and they're not very symptomatic, then I don't think you need to be subjecting them to repeated venipuncture.
Thank you. That is a much appreciated statement. So Claire, before I get to your question, just before it's almost 5 o'clock, as long as Kierston and Cheril are able to stay, we can have as many questions as we have time, or as people would like. But just so some of I've looked at it, I don't think it's possible to change your name for people who haven't used their own names as their screen name when they came on. I don't think it's possible to change that. So if you can email either Sarah or Flanagan or myself, and just to say that you've attended, then we will make sure people get their certificates, and also Sarah will send out an evaluation questionnaire as well. Dr. Mitchell.
So Cheril, I was just wondering what your thoughts would be about measuring prolactin at all in an asymptomatic person on an antipsychotic, because there are guidelines that say that we should, but then we end up in this position where there's like this case where there's excellent benefit from the medication and this mildly elevated prolactin. And if we're not going to do anything about it, I guess I wonder whether we should measure it at all. Yeah, so I'd be interested in your thoughts.
Yeah, I mean, pragmatically, I mean, I'm all for non-invasive. If you're not going to do anything with the information, I don't think there's any point. And prolactin levels 40, 50, I don't think are particularly a concern. And most of these adolescents are going to be on sex steroid replacements anyway, so you don't need to worry about their bone density. So I agree, Claire. I don't think it's necessary.
Thank you.
I just put this slide up because I missed it, just so you can look at that.
So when I was in second year medicine, or maybe third year, a very wise clinician said that we treat people, we don't treat lab tests. And that is something that has always stuck with me. And I think your point, Cheril, is very well taken. I've had several patients whose primary care physicians have stopped an antipsychotic because of a slightly elevated prolactin, with sometimes pretty significant deteriorations in their behavior and in their functioning, despite the fact they were asymptomatic. And it's created huge problems for them, I think, at times.
And I think, another analogy is TSH. I mean, I can't tell you how many referrals we get for a TSH, which is, just above the upper limit of normal. And then, the first question is, why did you measure it? Well, as a screen. Well, this, I don't think that should be done. And then you're caught in the whole chain of repeating levels, measuring antibodies. So I think sometimes we need to back off.
So, and so I think, Farah, I think that then answers your question as well. Dr. Ogilvie. Yep,
got it. Thanks, Dr. Clarson. That was a great overview. I guess I'm thinking about so is it fair to say that if the prolactin level is high enough to be a concern for those secondary effects in terms of bone density and inhibition of the sex steroids, is it going to be clinically evident, or is that not necessarily the case? Like, I'm wondering, can we go clinically for these kids who are on medications, and then also thinking about my for who are on these medications? Is that a fair kind of clinical assessment?
Yeah, and the prolactin level isn't necessarily related to symptoms. Okay, I'm not sure if that answers your question.
I guess I'm wondering about if we're saying we're not going to screen routinely because we may not act on it. There was that slide where you talked about it's not just about the galactorrhea being a lot of them are symptomatic. It's some of those secondary effects as well that it can have that would not be readily evident. There's something about bone, it has some role in bone mineral density, not?
Yeah. Good point.
Like if I've got a kid who starts it, say, at age 6.
Right. All right, so you don't really need to be concerned about the impact on bone density until pubertal age. And so my opinion is, since most of these adolescents are going to be on sex steroids anyway, then we're kind of that would be counteracting the impact of the prolactin in decreasing the sex steroids. Does that make sense?
It does for the Prader-Willi population, I guess, if we just think about it. I guess I started thinking
so
that Claire and Rob were talking more generally about our population.
Oh, okay, right. Yeah, so yes, that might be an issue. And so, I mean, I suppose for girls, I mean, if they're having regular periods, that's sort of a pretty good indication that they're adequately estrogenized. But a bit more difficult with boys. So you're talking about somebody being on long-term antipsychotics and the concern about bone density, basically.
Yeah, I guess I would caution us from going away from completely checking a prolactin. And I agree, we don't need to check it multiple times per year.
Right.
But
I think that's a fair point, that it would be important to check it maybe at least once a year anyway. And you're probably doing blood work for other things at that time.
Thank you.
Welcome.
So, Dr. Clarson, with I think it's slide number 27 there, but in this patient, I mean, how do we explain the fact that the galactorrhea only happened when she wasn't taking the oral contraceptive?
Well, I was hoping you weren't going to ask me that.
Well, I had asked Dr. Amos to see if she could draw out the different pathways involved, and we both had an incredibly hard time figuring that out because it seems there's a million different things going on.
Yeah, right, and what I did find was, one report of women on oral contraceptives, and that during the year after coming off contraception, then there was quite a high rate of galactorrhea and increased prolactin. I can't really elucidate the mechanism. I mean, and the best I could find was it was likened to galactorrhea after childbirth, but I mean that doesn't really make sense to me.
And I think Kierston, you and I were looking at something, and it suggested that what I thought was a remarkably high number of women in this one study. I think it was like 110 women or something like that taking oral contraceptives, who and a significant percentage reported galactorrhea in the times when in the week when they weren't taking the contraceptive, and it just struck me as a remarkably high number, given it's something as a male that I've never heard of before, and it seemed almost unrealistically high. I mean, is this, has anybody else ever seen that, where in people taking contraceptives, when they stop it, that they then develop galactorrhea in the week between contraceptives?
Actually, this paper that I was looking at, the relative risk was estimated at 3.1 after discontinuing oral contraceptive and was highest for the first year afterwards. But again, they don't give a mechanism. And also, you know, the doses of estrogen in OCP are much lower now than they were, you know, decades ago, when there were much higher reported rates of galactorrhea.
And so Farah has said here, obstetricians don't recommend estrogen-containing oral contraceptives while a mom is establishing breastfeeding because estrogen can lower milk. So, which would then imply, I guess, Farah, correct me if I'm wrong, that the estrogen then would increase milk supply. Correct?
Yes, yeah, absolutely.
So stopping the estrogen rather would do that, right? Okay.
Yeah, right.
So, I mean, with this patient, then, Dr. Clarson, if at some point, so we'll have to measure her prolactin level, but as long as her galactorrhea is not problematic, and I think she's had to wear some breast pads, I think that as long as it's not a problem, is it fair to say we just stay the course?
Yeah, I would say absolutely. And I mean, she's actually, I'm seeing her either later this month or beginning of next month. So we will be doing thyroid blood work because she's on thyroid medication. So I'll check the prolactin. But given the positive response to risperidone and the fact that she's on both growth hormone and estrogen, which both contribute to improved bone density, I would stay the course.
Tuche, you had a comment?
Yeah, I just wanted to say thank you very much, Dr. Clarson. This is very informative for us for me, because we see these patients at diagnosis and then usually no longer. But they do ask us about all of these possible implications of this diagnosis and what they may expect. Of course, it's a different conversation in the NICU and a different one if we see them at 2 or 3 years of age, but this is very, very informative for me to hear. We always read about growth hormone effects and the importance of endocrinology follow-up, but of course not case by case. So this was very informative for me. Just wanted to also close the loop on what Rob asked before about kind of genotype-phenotype correlations. There have been some papers that said, the larger, because there's 2 different types of deletions, larger deletion was worse than the smaller one, but they were not quite replicated in newer studies. But there is an interesting difference that maybe Rob may be interested in that individuals with UPD, so the uniparental disomy, were actually more likely to have psychosis and autism, whereas the ones with deletions were reported to have more compulsive behaviors, poorer adaptive behaviors, and more intellectual disability, which is interesting.
But any idea what the sample size was in those things, though? I mean, because we're talking about a fairly rare condition anyway.
Well, it's one of our more common genetic conditions, if you ask me. But yes, You're right. The sample sizes would be around maybe 100 if we're lucky. Yeah. I mean,
and the uniparental disomy would be what percent? I mean, what percentage of people with Prader Willi have uniparental disomy?
Yeah, like about 20 to 30%.
Okay, I didn't realize that. Okay.
So it's quite high still. So there's some psychiatric differences between the two, which is interesting to see. And I think it may be due to a deletion event rather than a methylation event that is the problem. But very interesting, and the positive effects of growth hormone just have been published on very, very much in the last few years. But again, as I said, some of the data, for example, in adults right now, are skewed, right? Because they did not have any treatment as young people with growth hormone or good endocrinology follow-up or good weight control. For example, when we look at adult studies right now, they actually see a 3% mortality every year for an adult with Prader Willi in a very recent paper from 2020 in Europe, where they looked at adults with it based on undiagnosed hypertension, undiagnosed high cholesterol levels, other endocrinological issues, and obviously obesity, low activity, and basically cardiovascular complications at a very young age, which I think will change how these kids do in the future.
That's really interesting, Tuche. Thank you.
Thanks.
All right. Anybody else have any comments or questions for Dr. Amos or Dr. Clarson? Okay. Well, Cheril and Kierston, thank you so much. I mean, this was a fantastic presentation, and as a psychiatrist, I think it was incredibly illuminating and really valuable, given what we are told in guidelines and things to think more practically. So thank you both of you. It was wonderful. I appreciate it very much. So next month, typically we have our sessions on the second Wednesday of every month. Next month, November the 11th is the second Wednesday, so we will probably do our rounds on the following Wednesday. We will send out an announcement about that. And if anybody who wants a certificate of attendance in order to get CME or CPD credits, please just email Sarah O'Flanagan or myself. And don't forget to check out our MySpace page. It may be the only one that is currently even close to active anywhere in the world. All right, thanks everybody. This was wonderful.
Okay, thank you. It's a pleasure.
Bye-bye.